Right, thank you very much. A little bit of audience participation. If you can't hear me, it's because I'm terrible at speaking up, so please wave at me and tell me to do better. It won't be taken in the wrong way at all. Please do let me know if you can't hear. A couple of quick questions. Who's from Scotland? Who's from England? The rest of the world? Fantastic. Who works in health? Quite a lot of you. Who's teaching? Quite a lot more. Industry? And civil service? Few of you. Right. I think what I want to do today, I think applies to all walks of life. There is that tiny advert for the Catholic Medical Association. There are Catholic medical quarterlies at the back, including Cardinal Nichols' address to medical students in November, which is on the web as well. And it's actually well written and well done, actually, and quite inspiring. So do please have a look. If you do work in health, think about joining. The Catholic Medical Association does lots of good work and needs your help, and actually it's there for you to protect and support you. And, you know, just as Mary, Dugan and Connie have needed SPUC and have done such a heroic piece of work, there's a real need to carry on working to do all we can to protect the patients and staff as they do good ethical medicine. Now, Mother Theresa wrote, "I've come to realise more and more that being unwanted is the worst disease that any human being can experience. Nowadays we found medicine for TB and consumptives, that's people with TB, can be cured. But for being unwanted, unless there are willing hands to serve and a loving heart to love, I don't think this terrible disease can be cured." With those words, she described the true essence of medicine and the true essence of so much of life outside of medicine as well. With the moves we've got towards euthanasia, the enforcement of advanced directives, the challenges of the Mental Capacity Act, these are all real threats to the security and dignity of vulnerable people, whether they're elderly, disabled, unborn, or in any other way unable to secure their own needs. And you know that under the Bland judgment, Tony Bland was described as being an individual with no best interest. His meaning became void because he wasn't considered to have any best interests. So the vulnerable become afraid, they feel insecure. Some want to be killed because they fear getting worse. And we'll come on to this. The most common reason for being asking to be killed is the loss of hope. And if we move, as we move towards that culture of death with physician-assisted suicide or whatever we're going to get, doctors will become worse at palliating distress, and care gets worse. And happily, Christian tradition is filled with a rich history of caring for the most vulnerable, right back to Roman times. Finish off with it actually, St. Lawrence was martyred for his defence of the vulnerable. And extraordinary things happened after the conversion of Rome. And nowadays the Catholic Church is still the largest healthcare organisation in the world, providing health in every continent, in every country, extraordinarily well, with non-Catholic Christian churches providing yet more. Right. This is actually not quite the right slide. Benjamin was £2, abandoned on the streets of Calcutta by a mother, probably starving with no means to care for him. And Mother Teresa found him, and he was rescued and brought there. And I remember Mother Teresa saying once that she picked a child off the street, and within a couple of days it had a sparkle in its eyes. Benjamin was very disabled, he had a severe cerebral palsy, and she too saw the sparkle in that child's eyes. And held him on her lap, took him to her orphanage, so he'd have a better chance of being adopted. And he was in the end adopted, went to America and lived with his parents who clearly love him very much. But I was always taken by that sense that Mother Theresa picked up the most abandoned children, and just very quickly, once they'd been fed, watered and given love, they would develop the sparkle that they had lost when they were rescued. And how beautiful that is. A little bit of history. Suicide, abortion and infanticide were accepted in Greek and Roman times. And there's an interesting field in Buckinghamshire, which is a burial ground for 96 babies, and there's one of the babies. And I don't know how many of you know about that, but the Romans would kill dozens and dozens of babies, and it's thought that possibly the site was a brothel, but whatever it was, it had a little door, and outside it, there's 97 newborns, and it looks as though they were left out to die as soon as they were born. And infanticide was widespread, actually. It's illegal today. It was the opposite to the Romans. The law made children under 2 the property of the father, to be disposed of as he saw fit. If it was deformed, you had to put it to death. And there's a letter from a Roman citizen to his wife, dating from 1 BC. I'm still in Alexandria. I beg and plead with you to take care of our little child as soon as we receive wages. I beg and pray of you to take care of our little child, and as soon as we receive wages, I will send them to you. In the meantime, if good fortune to you, you give birth. If it is a boy, let it live. If it is a girl, expose it. And reflecting on it, it is tragic, of course, that what we saw last week was that actually there's a statement we do not need to amend the law on gender-specific abortion. To be pro-choice, you really have to be willing to kill women. It's very difficult challenge. After Constantine made Christianity the official religion of the empire, the practice was banned. And we actually found a better way. Babies were no longer left out. Infanticide became illegal. But it is remarkable how accepted infanticide was. Suicide was also common, and those of you who work in health will know about NICE guidelines, where we work out the very best and most effective way to achieve the therapeutic end. And one of the very early models of the NICE guideline was the Greek guidance on hemlock, how to make it peak top-notch efficacy, so that it just worked just right, and they would prepare it, cook it, do all sorts of things to it, to maximise its effectiveness. So the Greeks really produced nice guidance on how to make hemlock as lethal as possible. And that was one of the challenges of being a doctor, to make things as effective as you can. So they were good at that, and they got good at killing. In Athens, the authorities supplied hemlock on request as long as patients gave their reasons to judges. Some had to go and plead with the Senate. And it was thought that suicide was a good thing if you did it for somebody else, which we'll come back to with some of the thinking on dementia now. When suicide is to avoid being made to do something unlawful, and when poverty, chronic disease, or whatever, being unwanted, makes death more attractive than life. In Sparta, apparently, so it's said in our time on the BBC, the enemies of the state were rarely executed. They all ended up negotiating with the state and requesting hemlock, which was then given out of kindness. How amazing is that? That you had a state that was coercive enough to make people want to request the execution the state was requiring them to have. And how vulnerable is that? And as you know, Socrates took his own poison and wrote all about what it was like to be dying of hemlock and things spreading up his legs and becoming paralysed. Roman citizens were allowed to kill themselves, and with that and the support of doctors, medicine became corrupted by its willingness to kill. And here you see in Romeo and Juliet, "O true apothecary, thy drugs are quick, thus with a kiss I die." Very, very good technology back in Roman times in terms of killing. Interestingly, in Rome, soldiers were not allowed to commit suicide because there was a fear the empire would be weakened. And those facing trial weren't allowed to commit suicide. So there was quite a severe punishment for any soldier who killed himself. How did they do that? Any ideas? How do you punish a dead bloke?
You take their land.
Take their land? Anyone else? Oh yeah.
Kill his friends?
More or less. And in Rome, death by poisoning was 9% of suicides. Oh, I've lost the slide. I do apologise. What they did was they dispossessed the family and children. So if you were out there fighting your war for Rome and you killed yourself, your family and children would be taken out. And the soldiers knew that. And they did that very well. So there was a real sense that actually some people couldn't, but there was an absolute acceptance that killing was quite okay. And in Sparta, there was also this corruption where the state would support the removal of unwanted people and opponents. And in the face of all that killing came hope with Hippocrates and modern medicine. Now, the other thing is abortion, which was also apparently common in Greece and Rome. Well, looking through some of the resources, some people say it wasn't, but many people say it was, and there were some special herbs again, silphium I think, which seem to have been refined and made maximum effectiveness to produce abortion as reliably as possible. And so doctors became good at abortion, good at killing, but not very good at the medicine bit in between. Hippocrates said, I will use those dietary regimens that will benefit my patients according to my best ability and judgment, and I will do no harm or injustice. I will not give a lethal drug to anybody. So he was absolutely anti-euthanasia. Nor will I advise such a plan. And similarly, I will not give a woman a pessary to cause an abortion. So he was specific that he didn't do those things. And I will do the best I can according to divine law. And following that, we got to the end of legalised child killing, we got to orphanages, we got to care of the vulnerable, care of the sick, care of dying and destitute. But Hippocrates was around 500 years before Christ, and that argument wasn't won until 374 AD. So actually it took quite a while. And actually, folks, your work is about building that culture of life, and building that culture that actually truly values the disadvantaged, the disabled, the unborn, and the vulnerable. But it is slightly shocking that it took so long to work. And the atrocities keep coming back. Here's a picture from Nazi times. Jews and Jesuits can't shoot us. Apparently doesn't. Those of you who speak German can translate that, but that's not told what it says. So actually there's been persecutions, there's been removal of vulnerable people, all sorts of things. And we know that Nazi times were, again, many of the things that were tried as war crimes were things like forced sterilisation and abortion in Slavic populations. All sorts of things that now we actually have in many ways legalised in this country. So where are we now? Well, we've got some bad care of the elderly. We've got some dreadful stories about poor care in the NHS. We've got problems with the Liverpool care path that we mentioned, and lots of challenges. Quick quiz. Which one of those two people has got dementia? They're both having lunch, sitting on a cliff. Not near the edge, I promise. Sitting on a cliff in Wales. Which one's got dementia? Hands up for him. Hands up for her. That was a tiny participant, right? Vote 2. Him. Who thinks him? Her? Can anybody tell? Nobody. Well, actually, you can tell. And I showed this to some lovely ladies once. And I said, so you can't tell who's got dementia, can you? She said, oh yes, we can, Doc. I said, how? They said, he's got the chip packet. He's in control. So she had dementia in that picture. So you can tell her. But actually the point of that slide is to say that actually with the thing that people think of as a great scourge, an advanced dementia, people can actually live well, contribute, and you can have good outcomes. And we need to remember that. So you really can't always tell. So, there we have a picture of someone with dementia contributing to family, out and about on a picnic, and here we have Baroness Warnock saying, there's nothing wrong with people being helped to die for the sake of their loved ones or society. I hope people will soon be allowed to put others down if they can't look after themselves. How awful and how callous. She went on to say, if you've got dementia, you're wasting people's lives, your family's lives, and you're wasting the resources of the National Health Service. And many of you will remember Richard Dawkins last year saying it's immoral not to abort a child with Down syndrome. Well, on a personal level, I'd like to say my younger brother had Down syndrome and gave me more than I could ever have imagined. It was such a gift. And to actually say it's immoral to allow that child to be born, it's quite shocking. Elderly people who are a burden have a duty to die, said Baroness Warnock. It's that awful. And imagine the bed of someone with advanced dementia who is frail and ill in hospital. And you've got the doctor, the nurse, maybe the son-in-law, and a couple of others around the bed, and the patient in bed, weak and feeble. Who's got the power? Is it the patient? Or is it the people around? The patient is the vulnerable one. The power is in the people around. Is it the son whose business is struggling? Socrates took his hemlock without a fight because he was condemned. Does the man who walks to the gallows commit suicide? No, he doesn't. Clearly not. And underneath that, you've got the dangers that poor skills make for bad deaths, and then you end up with an absence of services, which means that people tend to be funneled sometimes through acute wards, and that's a great shame. Good deaths and good care around death is a challenge to all of us. But to solve those bad deaths by enabling killing is a complete no-no, because it's actually going to take away the opportunity that you've got for other people to have good care. The Liverpool care pathway, which Tony mentioned, it was actually a disaster for many dying people. It persuaded doctors they could accurately tell when someone was dying imminently, and led to some very poor care and some very painful deaths by dehydration and things like that. And in fact, because doctors became used, in some circumstances at least, to prescribing medication before they were needed, it could actually cause death while staff thought they were following good practice guidelines. And when you think you're following good practice guidelines, you may be more dangerous than when you don't realise that's what you're doing, because you're being encouraged in it by a sort of national authority telling you to carry on. Any questions so far? Stunned silence, that's good. Right. Why do people want to die? Well, there's quite a few studies on that, but it appears that depression and hopelessness are the biggest factors associated with the desire to die. Lack of social support, untreated pain and physical functioning are also significant. But look, 58% of people, according to Chochinov in 2005, clinically depressed in terms of people asking to be killed. That's a huge proportion. So people ask to be killed when they're clinically depressed. The desire for death in terminally ill patients is closely associated with clinical depression, a potentially treatable condition, and it does decrease over time in many people. So clearly we need to influence the debate on euthanasia by pointing that out. And clearly we need to support people who are feeling hopeless, who are depressed, in feeling supported and accepting treatment and regaining some of that hope. And although depression is correlated with the desire to die, hopelessness is correlated even more highly with the desire to die. It's got the strongest association found so far. So for healthcare providers, providing hope is really central. Providing hope to someone, making them feel valued, making them feel wanted, making them feel that they're still contributing, and being with them and accompanying them can be quite life-transforming. Coming back to that in a moment. And in fact, spiritual well-being is associated with a reduced desire to die, and then there's also, as a significant factor, the fear of a loss of ability and dignity. And that's a real problem, because quite a number of people, when faced with the possibility of getting dementia or increased physical frailty and things like that, express the view that they would like to be able to die at a certain time. And a few people at least actually go off and get themselves killed before they reach the point where they can't do that. And that's driven by a fear of disability and a fear of inability. You'll remember that Debbie Purdy campaigned very effectively and vociferously for the right to have her husband kill her at a certain time. And in fact, as it turned out, of course, she died peacefully and well, so we understand, in a hospice. But she campaigned for that right, and some people are going off and killing themselves because they fear the uncertainty, and that is quite a difficulty. And our response to that, again, has to be to provide care, to provide good assurance that we'll be there to care, and to provide a good assurance that we will provide appropriate palliative care where we control and manage symptoms well and effectively while not actually killing someone. Because I think with well-controlled symptoms, those fears should go away. So key factors: loss of hope, depression, untreated pain, not enough care, and then some association with spiritual well-being, and also that thing around loss of ability and dignity. Although remember, that fear about loss of ability and dignity, if you've got depression in the large majority of people, is there coexisting alongside depression. So again, we'd like to be treating the things we can treat and providing the support that we've got the opportunity to provide as we go along. So how do we respond to the desire to die? Well, good care, good pain relief, treat depression, and the biggest thing is offer hope. Discuss the future with a real assurance of ongoing care and support. Discuss the future with that real assurance of good quality, appropriate palliation of symptoms when people have reached the point where they are not amenable to active life-saving treatments and things like that. And possibly contingency planning. Although I have to say that advanced directives and thinking too much specific detail about the future doesn't seem to reassure, and it may at times actually make things worse. So I don't worry about that. And use time. The desire to die changes enormously with time. How many of you in this room would like to get dementia? Good, you're awake. How many of you in this room would like to just die one day without much warning, but suddenly, so there's not a great process of suffering or anything like that? Quite a lot of you. And in fact, less than the usual population, so you're brighter and you've thought about this more, I'm sure. How many of you would like to die by the time you're 55 or 60? A couple. How many of you would like to live and see your grandchildren and possibly your great-grandchildren. Okay. How many people, if they live that long, are likely to end up with some degree at least of dementia? Quite a lot of you. How many people, when they get that dementia, can carry on enjoying their grandchildren and enjoying being with them? Quite a lot. So the standard response of, oh, I'd love to die suddenly when I'm 70 without any warning in my sleep, it's a great idea, it's got some nice things about it, but it's got some drawbacks too. And actually, what we find is that when people develop that dementia, when people develop that frailty, the way they think, the way they choose, wasn't expected in terms of what they wanted. So we have to provide that ongoing support, that ongoing discussion, and some ongoing assurance, that you can live well with dementia. Here's a story of someone that I was very privileged to get to learn. And this poor chap was only 52, and he had very severe pain from a progressive disease of his spinal cord. He'd been on very powerful injectors every 4 hours, and that hadn't really been working, and he was just in pain, and he longed to die, because he couldn't conceive what it would be like to live another 20 years with that level of pain. He didn't know he had a terminal condition. He thought he would live for many more years. In Lourdes, we gave him a diagnosis, we told him there was no cure, we understood his illness, and we discussed what we would do in terms of pain relief, and he found again a faith that had been severely battered by that sense of desolation and that complete loss of hope. He just didn't think he could cope with another 20 years of pain. He went in the baths twice at risk of his life, and he completed every bit of the pilgrimage. And he died 6 months later, but with a huge renewal of hope. So we didn't do anything. We didn't cure him. We managed his pain. We told him what was happening, and we told him what would happen. And that brought him back into a position of hope. And that's the kind of transformation we can see. And there are many dangers for the unborn. There's the unwanted baby who threatens the mother. There's the thing about babies with lethal abnormalities. Now, we've been very privileged to work with a number of women who've had babies with so-called lethal abnormalities. And our experience is that the majority of doctors, when counselling women, will tell them that these babies almost always die or will die before they're born. And they're virtually all off termination. Now, in fact, for the women that we've known who've kept those babies, they often have come to term, and they often have been born, and they've often lived for a while. Some have been stillborn, but families have still been able to hold the baby after it's born. That's been a great comfort. So the outcome may be a bit different. Got a couple of pictures of that in a moment. But now we've got a new suggestion that if you don't abort a disabled baby, that may represent torture. And one of the UN committees last year was talking about the use of torture rules to sort against the Vatican, because the Vatican is opposed to abortion. They're accusing the Vatican of torture, which is completely upside down, because of course we know that babies who are not wanted in utero so often become wanted when they're born, and many babies who were wanted in utero turn out to be a bit more challenging when they're born. I've not come across a parent yet who hasn't been at times slightly distracted by the challenges they're faced with their children, because all parents have challenges with their children. So there are many, many dangers for the unborn. And for healthcare workers, there are these accusations of torture, but actually if you don't offer an abortion, you may be putting that person into great suffering. Now, the only thing I would add to Paul's excellent summary on the mental health effects of abortion was that the methodology used by the colleges was so rigorous in terms of which studies they took, that by the time they finished, they removed all the studies on mental health and abortion except for 4, which they were prepared to analyse, a couple of which were really quite old and quite ropey. And interestingly, all of which did show that some aspect of mental health got worse in women who had had abortions. But they weren't all, in each study it was a different aspect, so they reached this view that there was no evidence. So actually there is a lot of evidence. The mental health of women who undergo abortions is worse than the mental health of women who don't. And there is evidence that there's at least a substantial probability, really, that some of that is causality. And there's a very beautiful study by Browen which shows that actually in the 3 to 6 months after a termination, the woman who's had the termination may be doing slightly better in many respects mentally than the woman who hasn't had termination. Well, guess what? The woman who hasn't had termination is pregnant, giving birth, losing sleep, up at night, and all sorts of things. But after that, if you follow them, the mental health of the mother improves, and the mental health of the woman who's had the termination often deteriorates. And I think that women who have terminations, I think they probably go shopping in Tesco's or Morrison's. And I think a number of them see 2-year-old babies with mothers playing and laughing. And I think they often think, gosh, maybe I could have had that. Because Browen showed that women do have that kind of flashback, that kind of psychological adjustment. So we need to support the mothers. We need to value the child that they might bring forth and to show that that child is valued and wanted. And if you extrapolate the accusation of torture, there's a suggestion, of course, of not giving a lethal injection may be torture. And we know of colleagues who did not want to put people on the Liverpool care pathway and were then criticised because it was held that they were then providing bad medicine. They should be using the LCP, even though they saw that it wasn't appropriate in those patients. And the accusation that denying an abortion is torture. So we have to work with all of that. And one way to work with that is absolutely to carry on saying that killing is wrong. We do not kill. We must remember in all that we do that we do not think that killing is the right answer for clinical care. The second answer, which will very often work much better, is on an individual basis to point out how wanted and valued somebody is. And there is someone with dementia, a couple of weeks before she died, on Christmas Day, with her family and with her grandchildren. That woman was wanted and valued. That woman was cherished. And some of the answer to all of this is to say, yes, we will cherish, we will care, we provide the best care, and that gives us the right opportunities, and we can do it with good care. Here's another woman, before and after discharge from the nursing home, and you can see that there is a picture of a woman who was very distressed. I do have the consent to show these things. And here is a woman, 2 years later, looking so much better, and that's completely outside of the expectation of what you think for dementia. You expect someone to be like the picture on the left and not to get better, but in fact with good care we can do that. And here's a little video. Where would you go if you were having a day out in London? Well, there we are, Bluewater. It's a funny old place. You've all got big shopping centres. But the really good thing about big shopping centres is that you can go and get inside them and have a cup of tea. And there you have someone with a very severe dementia, 3 or 4 years after discharge from the nursing home, and you don't know which one of those 3 has got dementia, because you can't tell. So actually we can have good outcomes, and we can do good quality care. And that lady had really had quite a lot of palliative care approach to try and reduce her distress and increase her comfort. And it was an example of how well it went. And here's a photo of a baby with one of those lethal abnormalities. And there she is, having been brought to be born. And there you see a brother looking dreadfully worried. Because there we are. But actually, the next day he was much different. And there's a sister with a valued and wanted baby. And my sharing of that is around saying that that week before baby Hope died was an astonishingly special week that brought great graces to the whole family. And here's another one, another child, oh hang on, who was again with another similarly lethal abnormality, told by the parents it wouldn't survive to birth. No, not told by the parents, told by the doctors wouldn't make it to birth. Told by the doctors things, how difficult things would be, and parents brought her to birth. And here she is at the age of 2 with her big sister. Oh, hang on.
She'll be able to walk and talk.
There we go.
Now, when she's up in heaven, she'll be able to walk and talk and run and what she can't do now. And she's very special and she's very nice, she's very cuddly, and she loves me, and I play with her a lot. And she's a special baby, and I love her. My baby sister's name is Josephine, and my
Wanted and valued, folks. The central bit of what we do is we care about each individual that comes to us. We care, we want the very best for them, and cherish them, and value it. Taking you back to St. Lawrence, the Emperor Valerian persecuted the Christians in the 3rd century AD, and he rounded up the Pope and executed him. And after the execution of Pope Sixtus, the prefect of Rome demanded that St. Lawrence turn over the riches of the church. The earliest source on this is St. Ambrose, and St. Lawrence apparently asked for 3 days to gather together the wealth of the church. And he went off and he worked quite swiftly to distribute as much of what the church actually had to the poor. And then on the 3rd day, at the head of a small delegation, he presented himself to the prefect. And when ordered to give up the treasures of the church, he presented the poor, the crippled, the blind, and the suffering, and said, "These are the treasures of my church." Well, some of you know he was roasted on a spit for that, and famously, once halfway through, he said, "I've been done on this side, can you please turn me over?" Buoyed up, I suppose, by the angels. But it's a picture of our response. Is that in every setting, and we could extend this into embryology, we could extend this everywhere. In embryology, every embryo is wanted and valued. And because there's such a wastage of embryos, we do not think it is right to be using that method. And there's a real set of concerns about that. So there you are. We must oppose killing, just as we were shown so eloquently this morning that we must oppose slavery. We must oppose neglect, and we must promote good medicine. And we want and we value, because every person has that value. And I do think and hope that by giving out that message of every person having value, that's one of the most powerful things we can do to support better ways and a better world.